Now, we've got our next speaker is Tina Purnat, Prajna Leadership Fellow of the Harvard T.H. Chan School of Public Health. She's joining us from the United States, so if you could just give us a moment to get Tina up on screen, that's fantastic. So Tina, welcome, and I understand that you've been listening to our first speaker.
Absolutely. I hope that you'll see that our talks will rhyme, and I hope that will encourage really great conversation.
Thank you. So Tina has over 2 decades of international experience in this field. She's led major initiatives at the World Health Organization, European Centre for Disease Prevention and Control, really in the information space of modernising how public health systems use data, technology and evidence. Her work focuses on strengthening public health systems and shaping policies. For reasons outside of her control, it says in the program, she was unfortunately unable to join us, but is present virtually from the United States. Tina, it's a great pleasure to have you here. Please take us away.
Thank you very much. I hope you can see my slides, yes. So good morning to everyone. Before I begin, I want to acknowledge that I work and live on the traditional and ancestral land of the Massachusetts, who are the original inhabitants of what is now known as Boston and Cambridge. And moving there and studying at Harvard has reinforced the importance for me of paying respect to the people of the Massachusetts tribe, past and present, and honoring the land itself, which remains sacred to the Massachusetts people. It's really wonderful to be here with all of you in so many different ways, and I really enjoyed also the discussion just now. We're all working to hold together the threads of evidence, care, and public confidence. And I do want to thank Professor Bohr and your team and the Academy for the invitation. I do wish I could be there in person, but current uncertainty around US border policies and travel for international researchers made that difficult for me. And so I am joining you virtually, but I do hope that this talk can contribute to your conversations over the next few days. I also have been thinking a lot about trust in health and medicine. My perspective comes from having grown up in former Yugoslavia and having spent years working in public health across Europe and globally, and now returning to study it more deeply in the ivory tower at Harvard. We meet at a moment when trust feels both fragile and fiercely debated, and we really got a great taster for this. Every day brings another story that says trust is broken or challenged in science, in medicine, in expertise, in institutions, and yet we've never had more access to information or more ways to check it. So why does confidence in health still feel so uncertain? And I've called this talk "Trust is a Verb" because trust isn't something we possess. It's something that we practice. Similarly, how care is something that we practice. It doesn't sit still. It's earned, it's expressed, it's renewed through action. Every conversation, every policy decision, every patient encounter either strengthens it or weakens it. So trust is alive. And like anything alive, it responds to care and to neglect. So today I want to talk about 2 things. First, 3 deep shifts that I think are changing how people relate to knowledge, science, and evidence. And then the second, 3 actions that we can take to make trust something we do again, like exercising a muscle as individuals, institutions, and communities. So for most of the modern era, expertise has been the cornerstone of trust. The idea was simple. If you study, you train, you master a field, you earn the right to speak, and people will listen. But that idea is being rewritten And across every domain of knowledge, from climate to health, people are claiming a different kind of authority. They say, I'm an expert in my own experience. And that impulse doesn't come from ignorance. It actually comes, I think, from frustration, from people feeling unseen by systems that talk at them but rarely listen to them. If you take, for example, women's health, for decades, menopause was a medical footnote, underfunded, under-discussed, often dismissed as just part of getting older. Then social media changed that. In Australia and beyond, women began sharing raw personal accounts of what menopause actually feels like, the brain fog, the insomnia, the sense of identity shifting under your feet. And these stories were honest, emotional, and deeply validating. But empathy quickly became a marketing opportunity. Brands realized that listening sold products. And suddenly there were powders and supplements and menopause chocolates, all wrapped in the language of empowerment. So Samantha Thomas and Sarah White that you see here, they recently described their research on podcast by ABC Radio Melbourne and Victoria. And here's a twist. Their research shows that many women knew the products were dubious. They bought them anyway, not for the science, but because of recognition. It wasn't the chocolates that mattered, but the feeling of feeling heard. And that's the heart of the shift. When institutions fail to validate the experience, the market eagerly nowadays steps in to sell it back to us. You heard about the Edelman Trust Barometer. Um, it tells the same story. People still trust my doctor, the person they know, but they distrust the system. So acts of care have become more credible than structures of care. And for clinicians, this is familiar. We know that empathy, time, and attention, those are the small human gestures that uh, signal care. They can change health outcomes. That's the so-called placebo or positive care effect. It's not a trick of the mind. It's when people feel heard, their physiology follows. But the health systems have grown over time more and more transactional. So we've squeezed out those very moments of connection. So when people can't find care that feels human, they look for it elsewhere, and even in places that may not be evidence-based. I discussed this recently with David Scales, a colleague at Cornell Medicine, and he sums it up perfectly. He says, we've gone from ignoring lived experience to worshiping it. And both extremes alone are risky. Experience tells us where it hurts, and expertise tells us why. One without the other leaves us lost or limited. So the task isn't to reclaim authority, it's to reshape it. It's to build relational expertise where professionals and publics meet as partners in understanding, not as competitors for truth. So expertise today isn't a fortress to defend. It's a bridge, I think, to build and to maintain. And the second shift is about tempo. We live in an information environment built for speed, not for reflection. Conversations that once unfolded within clear boundaries now spill everywhere at once. Social media has erased the line between expert debate and public dialogue. What once happened in closed rooms now unfolds in front of everyone, instantly and without context. And perhaps not the doctors and scientists in the audience today, but certainly the patients are more likely to watch a series of 60-second TikToks as compared to a longer, slower discussion that explains how evidence evolves. And this has been called context collapse, when the boundaries between audiences, settings, and meanings flatten. Claire Wardle, another prominent researcher in misinformation and health misinformation, she just last week in a podcast described what this feels like. She says that we used to live in rooms with windows where you could see out and still know where we are, and now we live in mirrors boxes. Our feeds reflect our own beliefs back to us, rewarding outrage and certainty over nuance and care. And that matters because the machinery of science runs on patience. Hypothesis, testing, replication, these things take time. But on the other hand, online, the rhythm of conversation is speedy and it accelerates. So David and I recently discussed this dynamic through the example of the Lyme disease controversy in France from a few years ago. At first, patients and scientists collaborated in France with genuine success addressing Lyme disease. They mapped tick exposure together, they crowdsourced data, and even helped shape research priorities. It was actually cited as an early example of citizen science working as intended, with lived experience informing professional expertise. But the breakdown came later when those collaborations moved into the politics of treatment guidelines. Online groups began to challenge infectious disease specialists, calling for recognition of chronic Lyme as a distinct condition. Doctors faced harassment. Some withdrew from the deliberations entirely. And patients, they felt abandoned, turned to alternative practitioners and conspiracy forums. So the conversation fractured into anger and into mistrust. And I think the failure wasn't the lack of participation, it was the lack of clear boundaries about what kind of participation was happening. So the boundaries between generating knowledge and deciding policy, or between debating evidence and advocating for care, between the dedicated space of expert deliberation and the open space for public discussion. And these boundaries matter because they protect meaning of the conversation. Without them, the expectations then blur. Scientists think that they're debating data, and the patients think that they're deciding treatment. And the result is frustration on all sides. So I do think that we need to design participatory discussion forums and roles that make purpose explicit with such clear boundaries. And I will talk about this later on, because I think this needs intentional action and thought to be rebuilt. If we want trust to last, we have to give it time, context, and structure so that participation strengthens expertise instead of dissolving it and questioning it. The third shift is cultural, and it cuts deep. We live in an age obsessed with personalization. Medicine promises to tailor treatment to your genome. Streaming services predict what you like before you do. Even your search results are uniquely yours. And that feels empowering to people. It offers a sense of control in a world that often feels uncertain. But when every other part of life is tailored to us, then we start expecting science to do the same. We want our experience to define what's true. So we start to ask not, is this true? But is this true for me? And you can see it everywhere in home testing kits, wearable trackers, personalized supplement programs. Each of these promises agency, mastery over our data, our bodies, and our health decisions. But when that sense of control also changes what people think science is for, when evidence speaks in averages, it can feel impersonal to people. And when medicine speaks in probabilities, it can sound dismissive. So personalization actually makes uncertainty feel like a failure of care. There's a new book actually coming out in February 2026 by Sarah N. Singer. She calls this situation the paradox of empowerment. Health information has never been more accessible, yet the very accessibility shifts the burden of the responsibility. If we're told we have all the tools to manage our health, then being unwell starts to look like a personal shortcoming. Didn't find the right diet, didn't try the right supplement, didn't optimize hard enough. And what was meant to free people from dependence instead creates a new form of pressure and a quiet moral judgment disguised as empowerment. And it tells us that good health is not only our right, but it's our duty, and that failing to achieve it is also a personal fault. And this shift matters for trust because it changes how people interpret vulnerability. If health becomes purely a personal project, then the institutions built to protect collective well-being begin to seem irrelevant or even obstructive to my choices. So to rebuild trust, we have to connect the personal and the collective again, and we need to protect that. Science must speak to both the individual experience that asks, is this true for me? And also to the the shared evidence that answers, here's what's true for us. And trust grows in that space where individual meaning and collective knowledge meet. So if those are the shifts, then how do we respond? And how do we move from diagnosis to practice, from nouns to verbs? So in the first half of this talk, I will, if this was about seeing the landscape clearly, the second half is about how we walk through it. And I want to propose 3 ways of treating trust as a living, ongoing verb: acting in ways worthy of trust, renewing the social contract across generations, reimagining how science and society walk forward together. And each of these is less a strategy than a posture, sort of a way of moving differently in a world where confidence from people must be earned again and again. And so if we look at the first one, it might sound obvious, but it's the foundation for everything else: acting in ways worthy of trust. Trustworthy systems are built through trustworthy habits. Today, people don't primarily trust titles or credentials, they trust behavior. And the behavior they're watching for from institutions, for example, is practical: how institutions respond under pressure, how they handle mistakes, and listen when consequences are uneven. You heard this in the previous talk as well. So when I talk about acting in ways worthy of trust, I'm not only referring to better communication or engagement. It's about how our systems work, how decisions are made, how workplaces function, how our professions live up to the values that we speak about publicly. Because people don't learn about science or medicine only from what we tell them, they learn from what they see of us, how we act when the stakes are high and when no one's watching. And you can see this everywhere once you start looking for it. I spent the last several months working in New York, for example. The community health workers there are the bridge between the New York City residents and essential health and social services like healthcare, childcare, housing, food, and legal support. And they all told me the same thing: that trust is the currency that makes any of it possible. When trust is low, people hesitate to reach out, unsure who to believe or where to turn. And every like even small doubts can unravel those threads that connect families to care. Parents are unsure their children qualify for pre-kindergarten, or immigrants avoid clinics out of fear that it might affect their legal status in the country. And health department staff do their best to bridge that gap, but they're doing it in a system that is stretched thin. And the result is measured not in abstract statistics, but in missed care, delayed diagnosis, and preventable suffering. And that's what I mean by acting in ways worthy of trust. It's not an abstract idea. It's what happens when people on the front lines, those with the least authority but the most contact with people, they carry the moral weight of a system that was supposed to have their back. And that's where the rebuilding, I think, has to start, by strengthening that everyday relationship that holds the whole system together. Then, trust often grows through small, visible actions. When clinicians explain uncertainty instead of hiding it, when scientists share credit, when agencies show how public feedback changed a decision, all of these moments build confidence that the system acts in good faith. And we can see this in how some governments have experimented with citizen juries and public deliberation panels around contentious health topics. I display a few here. So in Scotland, for example, citizen deliberation panels brought together randomly selected citizens, teachers, retirees, parents, to hear evidence from scientists and ethicists before forming their recommendations around COVID-19 policies. And in France, the vaccine citizen juries offered a similar model where citizens examined expert testimony, they debated risk and responsibility, and they produced nuanced guidance that informed public policy. And these examples, these were slow, deliberative bodies that were very different from the fast, noisy arena of social media, because they gave people time to think and to weigh the evidence and to deliberate without pressure. And the result was better decisions and stronger trust in the process as well. Another example, for example, during the pandemic, some leaders showed what kind of trust, what that kind of trust building looks like in practice. And I'm showing here Alison Arwadi. She was then Chicago's public health commissioner, and she held unscripted weekly Facebook Live sessions where Chicago residents could ask questions directly. There were no scripts or talking points. There was just an open conversation. And people tuned in because they could see an honest effort to engage and to explain uncertainty as it unfolded. And many Chicagoans loved really the way that she was handling the pandemic response. Now, her openness didn't erase disagreement, but she did make disagreement feel safe. So the consistency, the transparency, the humanity mattered more than flawless accuracy of what was said. And all of these examples that I just showed, they can remind us of the saying that talk is cheap and actions speak louder than words. Trust grows when people can see the principles behind the decisions and when transparency is lived rather than declared. And in the end, credibility isn't granted by authority, and instead it's earned through actions and behavior. I also wanted to point out that we need to think about how we protect the trust that health and medicine are currently enjoying, even as trust in institution is eroding. And across the board, one of the trust indicators we are counting on always is people's high regard for doctors, nurses, and other health professionals as the most trusted sources of health information, for example, for public health action. And we act as if trust will always be there. And we recommend to people, if in doubt, talk to your doctor. And that's good advice, but only if doctors have the time, the space, and support to have that conversation. Without that, we're asking clinicians literally to hold up the whole system of trust on their own. And at the same time, people now research health information online, both before and after seeing their GP. And meanwhile, wellness influencers have learned to fill the emotional space that health systems often leave empty. They offer presence, attention, reassurance that many wish medicine had more time for. So if we want trusting clinicians to endure, we have to care for the conditions that make it possible. And that means giving health professionals time to listen and options to refer and protection when they engage in digital spaces. So trusting clinicians remain one of our greatest assets, but it isn't self-renewing, and it will last only if we invest in the people who hold it for us. The second thing, second action that I'm proposing is about continuity and change. Trust isn't a single conversation. It's a thread that runs through generations. It's shaped by history and experience. For all the generations, trust was built through deference. Let me actually display this data for you. You listened because the expert had earned the right to speak, and they saw expertise as authority and institutions as anchors of reliability. Then Gen X came of age during a time of institutional failure, the AIDS crisis, tobacco cover-ups, decades of neglect in women's health, for example, and they learned to ask questions first and not after the fact. Many women, for example, in this generation describe years of being dismissed or disbelieved. Studies show women wait longer in emergency departments for the same symptoms as men and are more likely to have their pain doubted. So when we see today's menopause moment online, it's not a wellness fad. It's been called a reckoning in women's discussions. It's a demand for empathy after years of invisibility. And when institutions fail to show empathy, people go looking for it elsewhere, even when that elsewhere offers shaky advice. And then millennials and Gen Z, they live in a different world altogether, and they've grown up surrounded by information, not waiting for it. So they expect openness and value authenticity over authority, and they trust people more than systems, and they build understanding by comparing across peers, creators, and clinicians. And that's not the defiance of authority. It's I think, a new kind of trust literacy. So renewing this social contract begins with recognizing these differences and listening across them. And what can look like defiance to science, it's often a request for dialogue. Uh, I don't think people necessarily are rejecting expertise. They're asking it to meet them where they are. And in this space, you can see this shift, I think, inside our own professions as well. Younger clinicians, nurses, public health students, they're finding their voice in workplaces that still reward hierarchy and caution. They want to speak directly with the public, to explain what they know in plain language and in real time. And when the system doesn't make space for that, they make it their own. So every day you'll find them online. Doctors unpacking vaccine data, dietitians debunking nutrition myths, students explaining epidemiology. And I think that's generous work. It's often unpaid and often it goes unacknowledged. And they do it because they care, not because someone told them to. Yet this work still sits in a gray zone. It's celebrated when it's convenient for us, but it's unsupported when it matters. There's little mentorship, there's few protections when visibility online turns hostile, and almost no recognition that communication itself is care. So if we want the next generation to use these spaces with confidence, we need to treat them as part of the professional landscape. And that means mentorship, training, protection, and time. And yes, it also means thinking seriously about how to fund this, whether it's through grants, through partnerships, or even platform levies that support public interest communication. Because this generation isn't waiting for permission to join the conversation, and they already live in it. They're shaping how health and science are understood, one video, one post, one patient at a time. So renewing this social contract means also meeting them there and learning from their instincts. So in conclusion on this point, I think really inside and outside of our own institutions, trust goes exactly the same way through small acts of respect that we repeat over time. And this brings me to the third action. It's about how we move, how we rebuild the pathways between science and societies that it served. We've already talked how expertise is changing, how conversations are speeding up, how each generation defines trust in its own way. All those forces meet here because trust isn't only about what people believe. It's built in the places where discovery, decisions, and dialogue come together. And for years, whenever trust started to slip, our instinct was to defend. And we used the language of defense. Some professional associations and coalitions across North America and in Europe, they launched campaigns that said things like stand up for science and trust the experts. But defending doesn't build connection. And people aren't asking us to shout louder. They're asking us to share the work of understanding. And right now, everyone's talking about health, scientists, policymakers, the public, but they talk at the same time and are making a lot of noise online and often drift apart. So if you want to rebuild trust, I think we have to rebuild the structure of these conversations. And to do that, I find it helpful to think about a missing piece, what I call the middle layer between the science layer, where scientific knowledge is made, and the public layer, where the health and evidence are discussed in the public. And what I think we need to do is rethink the in between the two, a kind of connective tissue that helps sense make between science and the public. So I think when trust falters, we usually focus on the two ends of this spectrum, the research that produces evidence and the communication that spreads it to the public. But the real work of understanding happens in between. It's where the evidence, experience, and values come together before anyone declares this is settled. And this middle layer is the space where scientists, policymakers, patients, and communities can sit together and weigh risks and the trade-offs and priorities, because it's less about expertise and it's more about building a shared way of reasoning together. And we already have small versions of this, for example, in medicine. Ethics committees help clinicians work through tough moral questions. clinical guidelines, the panels, clinical guideline panels, they bring doctors, statisticians, patients to the same table to figure out how evidence should shape care. I mentioned citizen juries on vaccines or genetics. They invite ordinary people to hear experts, ask questions, make recommendations that blend data with lived experience. And these are structured, transparent, and slow by design. And that's exactly why they build trust. But we need that kind of structure across science and public health more broadly. There's examples, for example, also of science media centers. They do some of this work already in some countries. They connect researchers with journalists, and they give context when stories break. They help the public make sense of new findings. They're useful, but they're not, they're only one part of the system. I think we also need to think more about science deliberation generalists, people who can connect across fields the way that a GP connects specialist clinicians and patients. And that would mean social scientists, clinicians, ethicists, patient advocates, community leaders who can translate across boundaries and keep the conversation coherent and contextualize it. What I mentioned before, the keeping the boundary and awareness of the purpose of the conversation. So their role would be, I think, to make science, or their role is to make science understandable without watering it down, and to connect the details of research to the realities of people's lives. So it's literally meaning making together. And that balance takes time and attention. So at the same time, not everyone with lived experience wants to join a formal panel, and not every scientist wants to speak in public forums, and that's fine. What I think matters is that we build bridges between those worlds in the form of spaces that protect the quality of the conversation, while at the same time widening who gets to be a part of the conversation. Because I think when this middle layer disappears, everything starts to unravel, which is what we've seen in again and again in certain situations, when expert debates spill into social media feeds without any context. So certainty starts to sound more convincing than honesty. And the slow, careful process of thinking things through, which is the part that makes science trustworthy, that gets lost. So rebuilding this middle layer and imagining what that would look like and how to do it shouldn't be about secrecy. Its focus should be on creating the right conditions for clarity. Conversations that are informed before they spread, inclusive before they trend. So I'm talking not just about making a place, but thinking of this also as a function and a civic habit of reasoning together. And if we can strengthen that habit, we'll be well on our way to rebuilding trust. Last point on this last action. For shared reasoning about health and medicine to work, I think we need a clear public language for uncertainty. And actually, I think we already live with it every day. Think about our decision-making around weather and forecasts. During the pandemic, for example, masks were compared to umbrellas. You don't use one every day, but when the forecast looks stormy, you keep it handy. And that's the kind of thinking we need in health and science. As a public health practitioner, I was trained to see uncertainty not as a flaw, but as something to assess and work through. Our tools and ethics are designed for it, but we weigh risks, act to reduce them, and stay ready to adapt as evidence challenges. But outside professional circles, uncertainty often feels different. It can seem confusing or even unsafe, especially online, where confidence often sounds more convincing than honesty. People look for clarity and belonging when things feel uncertain, which is human, but it can also pull us away from the careful, slower conversations that science needs. And that's why health and medical professionals must show what it looks like to act with care, even when not everything is known. When we explain how decisions are made and how our understanding changes, we help people see uncertainty not as a failure, but as a progress. So confidence doesn't come from pretending we're certain. It comes from showing that learning and action can happen at the same time. and that care, like science, keeps moving forward even when the path ahead isn't clear. So let me close with the simplest idea of this talk. Trust is a verb. It's something we do, not something we have. At the start, I said that all of us in science, health, medicine, policy, we're all trying to hold together these threads of evidence, care, and public confidence. And those threads have carried us through crisis and uncertainty, even when the weave felt thin. Everything that I've talked about today, acting in ways worthy of trust, renewing the social contract across generations, reimagining how science and society move forward together. This is really about the same act of weaving evidence, care, and policy confidence together. Trust is not built in statements, it's built in those stitches and actions, and it grows from how we show up, how we listen, and how we decide when things feel uncertain. And each conversation and each act of care is another thread pulled through. Over time, those threads form the fabric that holds science, health, and society together. And the work ahead is not to guard trust like a treasure. We must keep weaving it with patience, with humility, and with care until it feels whole and strong. Trust lives in that motion, and it holds us together. One act, one thread, one conversation at a time. So thank you very much.
Tina, thank you. I think I speak for everyone in the room that this is actually a perfect and deep and thoughtful enumeration of the problem and our way forward. Thank you so much. That was fabulous. Now, we have about 10 minutes before morning tea for questions and comments. Just put your hand up and I'll do my best to direct. Thank you.
Thank you. Wonderful, wonderful lecture. Andrew Davidson from Melbourne. A lot of our information in science is disseminated through journals. And as an editor, I'd love to hear your reflection on what can journals actually do to increase the trust in what we publish?
Did you hear that question?
Yes, I did. Journals have an important role to play in the information ecosystem, especially nowadays. I think it's not news to you there. I think the efforts around publishing statements, so accessible statements on the relevance of the paper or the contribution to knowledge or to the field are really important. But where a lot of things, when you look at how, for example, preprints or papers are used nowadays in public discourse, especially online, importance in being aware of the editorial policies, the review process, transparency around corrections, retractions, etc. It's really important to engage in this. I think journals probably have some role to play also in rethinking on how to engage with scientists also in communicating this and possibly also collaborating with journals on this. One thing that makes me really uneasy in practices that I've seen also regarding publication of science, and this perhaps isn't the responsibility for the journals per se, is publishing press releases on particular studies that sound really great, that end up being picked up in social media and in newspapers and on platforms, but actually are really not great representations of what the study said. So literally promoting each individual study through press releases. It requires also action and collaboration between journalists, and science communicators, and actually really strengthening the ability for people to end up using the research better. I definitely would encourage more. This is probably where discussions in the academy would probably really be beneficial. But it's in a really important role for the journals when it comes to science communication and the engagement piece and ensuring transparency.
Okay, thank you. Our second question, and then third over here.
Gary Anderson, University of Melbourne. I was shocked to learn that almost half of all US physicians subscribe to open evidence to guide their practice, and patients are increasingly using AI tools to access medical care and information. Congress is considering registering AI as prescribers of medicine. What do we do in Australia with these technologies? In the context of trust and trustworthiness.
Yeah. Every doctor, every pharmacist, every psychologist, mental health practitioner, they need to be licensed, and they work and they practice within the guidance and the standards of their profession. AI doesn't have that. It might be really great, psychopathic. It can really create feelings of empathy and intimacy with people, but it cannot, in my opinion, replace the responsibility that a human professional currently has within the responsibility of their profession. And I don't see the industry at all allowing virtual doctors, virtual mental health providers, etc., to be licensed. And I think actually they wouldn't pass licensing in my view. So like really not thinking about it from the point of view of consumption and the products that the industry is trying to create, but really thinking about the practice and what kind of governance and what kind of standards in practice are there, and then how the tools, whether it's GPT, etc., actually fall in. And then there's the second thing, and that's something for another discussion. It definitely is concerning how much people are moving to GPTs for medical advice, and this is already a real issue. Actually, just this morning in The Guardian, I was reading a profile from a story of experience of someone describing their mother in China who's a chronic kidney patient, literally developing a relationship with GPT because she has less of an access to a doctor that's too far away. So that's a real issue that we need to deal with as well.
Thank you. Emily.
Hello, Professor Emily Banks, epidemiologist and public health physician from the Australian National University. Thank you so much for a really riveting, beautifully eloquent talk. I was wondering about the issue where the lack of trust is not a lack of communication or any sort of error. It's actually a deliberate strategy. So we know from the tobacco industry, when they were faced with clear evidence of harms, they said doubt is our product, and actually actively seek to create misinformation. And we see that with a number of different vested interests, and there's a hugely disproportionate access to resources in terms of communication and the control of the narrative. And I'm just wondering if you have some advice for us about that particular aspect of breakdown in trust, where it's an active effort to reduce trust, and to create doubt.
I totally agree with you. This is why, and Australia is also one of the leaders in thinking about commercial determinants of health. And I would encourage lean in and please continue being leaders in the global space on this. It is extremely important to discuss this because we are seeing more and more harm in different aspects of health where it's very clear that commercial interests are harming health instead of promoting it. I think, for example, from the platform's point of view, like I mentioned in my talk, we need to really be thinking about the issue is that we don't compete very well with and counter and detect or being able to counter these efforts very well, because we also don't have as much funding and access to the strategies that to counter what the industry is doing. I think we need to think out of the box, maybe even levy the platforms in order to fund public interest health communication, like really thinking out of the box, because this is real. I was watching from afar the conversations in Australia, for example, about the debate around mental health of adolescents and the limits on use of social media, and the narratives around empowerment of parents, and that it's a choice of parent and the child, etc. That was very much supported by the platforms, and the narratives around whether or not that age can be the term age of a user can be determined, or that it cannot be determined. That is also very much supported by the platforms, even though we know that commercial design of our information space and the marketing space very much can profile every user individually online. So we need to be also clear about the interest of commercial interest. And if you look at the history of tobacco control, only when the harm was documented and was so obvious was then the pushback in regulation, and there was buy-in to introduce regulation of tobacco products. And I think we need to really put an effort into documenting the harm and then advocating for this. It's a harder conversation to have overall about commercial interests, but specifically acting on very obvious concentrated harms that we're seeing from different commercial activities. We need to really build on it, and we need to push back on it. And solutions might not always be perfect, but we need to be doing that actively.
Thank you.
Keith Martin from the University of Melbourne. Thanks, Tina, for such a thought-provoking talk. When we ask for trust, we are causing people to make a decision about what is real and what is true, and that determination is becoming increasingly difficult, as we've heard, both through misinformation, through everything from hallucination of AI to deep fakes to influencers with disproportionate access to the airwaves. And the one problem is that the more we educate people around avoiding being misled, the more we make them skeptical about what's actually true. And I think there are studies that are showing that now, that the more you educate, the more you erode their ability to trust true sources. So how do we deal with those two things?
Not to posit it as we need to convince and we need to arrive to the same conclusion on what is fact and what is true, but actually involve both be together involved in the conversation and the sense making. So in the previous talk, you heard that trust is interpersonal and relational, and that's actually what we're forgetting. It's not a matter of persuasion. It's involving in a conversation that doesn't end with one conversation, and forming meaning together. And for a scientist, they would learn from lived experience, and it might improve, I don't know, design of an RCT and the recruitment strategies for an RCT, but for a patient that is participating in that conversation, they link it into their patient advocacy, their experience, and their seeing being reflected, for example, in research. It's a conversation together. It's making sure that we have a common meaning making and deliberation, and then the benefits to different people that participate in conversation might also be different, not just making sure that there's a common reality together. And that's tough, because that also means that solutions around what you would do in digital spaces, like I've been advocating for, we need to have digital community health workers, and we need to figure out how we are present in online spaces where people are asking questions, where we're supporting the conversations online. And still often in public health or in science communication, we only go online when we have something to say, to push on people, but we're not there present in the conversation together with people as they're sense making. And doctors know this in the interpersonal level, but we need to reimagine this in many other spaces where people want to sense make and they ask questions where it makes sense.
Thank you. Last question, and thanks everyone for going a little over. It was such a rich presentation.
Thanks, Tina. This segues into my question. Harriet Hiscock, I'm a paediatrician from Melbourne. As you alluded to, we've got a ban on social media for the under 16-year-olds coming in December. How do we earn trust with the next generation of Australians if we're stopping them go where they go for their health information now?
Yeah. Mandates and bans are a radical solution, but that means that they're not the solution if you don't also think about the complementary things that you would need to put in place in order to have conversations about health. It's a tough choice in this debate. I've observed the benefits of social media for young people where they find connection and community. But on the other hand, when the harm concentrates and where it's concentrated, it's much more difficult to address because of the social pressure. No one is gonna stop using or reduce their use of their mobile phone if it's expected for if it's not actually, if their peers are also not adapting the behavior. So when it comes to health promotion, yeah, it's going to be much tougher, but there needs to be a reimagining and strengthening other type of engagement and really working with the kids and actually ask them, okay, if this is what is happening, how do we create spaces for them to actually access health information and discuss it? Kids should be part of the conversation. Should have been part of the conversation at the beginning.
Thank you very much, Tina. So if I could ask everybody, please thank Tina again for a fantastic conversation.